Tapas Das from BARC. The title of the talk is Development and Therapeutic Use of 90 yttrium glass microsphere, which is a Bhabhasphere, for affordable treatment in liver cancer.
Namaskar. Good afternoon to all of you. So, at the outset, I thank Professor Bhargava and Professor Santodhara for inviting me and giving me this opportunity to share one of our recent work, which we have done in Radiopharmaceuticals division of Bhabha Atomic Research Center. But before I start the presentation, I must admit that I am really a misfit in this forum, because I don't know much about the glass or ceramic, neither do I work with those things. My only connection is that we have taken little bit of glass, or you can say the glass microspheres, and we have put, or we are able to put some radioactivity inside that. And those radioactive glass microspheres, we have used it for the treatment of the liver cancer patients. And today it is, we are able to take it to the patients, and quite a good number of the patients have been treated with this. So I will share our experience with you. But before that, let me give you a brief idea about the liver cancer scenario of the world. So in 2020, there are around 9 lakh patients who have been detected with liver cancer, and out of it 8,30,000 patients died. So it really shows us a very deadly disease. And in 46 countries of the world, it is the third cause of cancer-related deaths. Third most cancer-related death happens in liver cancer. And liver cancer is the 5th most frequently diagnosed cancer in the world, but it is the 2nd most frequently cause of cancer-related deaths. Again, that shows it is really a very difficult to treat disease. And in women, it is the 7th most commonly diagnosed cancer and 6th leading cause of cancer-related death. And if you look at the Indian statistics, if you look about the 1 lakh population, it varies in different states to state. It is between 1 to 7.5 males in 1 lakh population. For women, it is much less. As you can see here, it mainly affects the male population 4:1 ratio. It is quite prevalent in some countries like China, Hong Kong, Taiwan, New Zealand. In India, it is a bit less, but we are fast catching up. So the number of cancer cases is also increasing in India. So this slide, which is given me by Professor Dhara's student, Sayam. So you can see here the different stages of the liver cancer. So when it is the early stage, then slowly you see the nodules are increasing, they are going to the difficult and difficult to treat stages. And this is usually staged by the Barcelona clinic liver cancer staging. And when you have the limited number of nodes, say there is 1 node or few nodes, you can treat those patients by surgical resection or by localization. But when we reach somewhere here, say the patients having multiple nodes, it's really difficult to treat, because you cannot do the surgery for this kind of the patients. You cannot go on doing continuously chemotherapy because these are toxic materials. So that time, but these patients has a good life expectancy, somewhere between more than 1 to 2.5 years. So only option is to treat either by these two methods, chemoembolization or radioembolization. Before I go to what is chemoembolization, radioembolization, let me just give you a brief idea about how the liver gets its blood supply. It's a very unique organ, and it gets blood supply both from the hepatic artery as well as portal vein. But the major blood supply comes from the portal vein. Almost 75 to 80% blood supply, which is basically the nutrient-rich blood, it reaches to the liver from the portal vein. While only 20 to 25% of the blood, which is oxygenated blood, reaches liver through the hepatic artery. So what is the role of this dual blood supply? The advantage is that, see, when there is a cancer in the liver, those cancer cells are fed only by the hepatic artery, not by the portal vein, because they need oxygenated blood for continuous growth. So if you can put something in the hepatic artery, some cancer drugs, some radioactivity, it will definitely reach to the, or majorly it will reach to the cancer affected cells. But the remaining portion of the liver will still function because it gets the major supply from the portal vein. So this is a big advantage for treating the liver. So we can very easily achieve the target specificity or put the drugs in the target. So from here the concept of embolization came. Embolization means you are cutting off the blood supply. So we put more microspheres in the hepatic artery. So it goes to close to the tumors or cancers and first the cut off the blood supply so that it don't multiply further. Now if we put some chemotherapeutic drugs there, so we call it TACE, transarterial chemoembolization, or if we put the radioisotope there, we call it TARE, transarterial radioembolization. So what are the agents available for the transarterial radioembolization? At this moment all over the world, these are the three agents which are available for the treatment. First one is called ⁹ This is basically a 90 yttrium level resin microsphere. Basically this resin is benzene styrene. As you can see, these are the ⁹ microsphere and it is the product. This is called ⁹ This is actually 90 yttrium level glass microsphere where 90 yttrium has been embedded in the glass. And third one, which is not very popular at this moment but used in some countries, called William spheres, which is 166 holmium based agent. Basically it is holmium based polylactic acids. So why we want to develop a biosimilar of this ⁹sphere, which is called ⁹sphere. So this I have taken from the internet to see the cost of the TARE process in India. It states that its cost is around 25,000 US dollars, which is roughly 20 lakh, 25 lakh rupees in today's time, and which is mostly unaffordable to majority of the Indian populations. So we wanted, why not we develop our own product, a biosimilar, which will be able to offer our Indian population at a much cheaper price. And this will help to reduce the dependency of costly imports. It will improve the access to the advanced cancer treatment, and it is in the line of our Honorable Prime Minister's call towards Atmanirbhar Bharat in nuclear medicine sector. So we are not very familiar, as I mentioned, with our glass or ceramics. So BRC is luckily a very big multidisciplinary organization, and we have our colleagues in the glass and advanced material division with whom we collaborated and requested them to develop the material for this ⁹sphere type of thing. So what they have done is, we have taken the yttrium oxide, aluminum and silicon dioxide. You are very well aware that silicon dioxide is a primary glass former. Aluminum oxide is a stabilizer and network modifier, and inside that we have put yttrium oxide. Yttrium is an element which is mononucleotic. Its 100% is 89 yttrium. So if we put it in the reactor, what will happen? 89 yttrium will become 90 yttrium, and 90 yttrium is the radionuclide which is having the maximum beta energy whatever is used today in the nuclear medicine. Because we want a higher beta energy particle, we have to treat a very big organ, liver, and it has a half-life of 64 hours. So we have developed this glass. First it has been mixed, melted in a platinum rhodium crucible around 1550 to 1650 degrees Celsius. So once it is thoroughly mixed and then we have grinded it, we have got the fine glass powder, then it has been done by flame periodization or spray dye to get the final aluminum silicate glass microspheres. Its density is 3.6 gram per cc. Size distribution is between 20 to 30 micron. This is required because we have to do the embolization. This is the perfect size for doing the embolization of the arteries for liver, which feeds the liver. Sphericity is 95%, 95% perfect spherical. They are smooth, non-porous, and 90 yttrium is very uniformly distributed throughout the matrix. So it has been characterized by different techniques, as you all aware, SAME, XRD, EDXRF, and also particle size is determined because it is extremely important. We have to discard all other particle sizes which are only between 20 to 30 or 35 we have taken. And now our role starts. So these glass microspheres, what we have done is that we have put it in what ambule. I will show you some photographs. Then we put it in the aluminum container and placed it in the reactor. You know, we have a reactor that's called BHUVA reactor in our campus, where we have irradiated it into 1 into 10 raised to 14 neutron per centimeter square per second neutron flux for 3 to 7 days. So what happened is that 89 yttrium absorbed the thermal neutron, produces 90 yttrium, which I mentioned. It is having a 2.27 MeV beta energy, which decays by emission of 2.27 MeV beta particle, and it has a half-life of 64.1 hours. Now, once the irradiation is completed, we allowed it to cool for 1 day, because if any short-lived radioisotope is produced, that will decay. We brought it back to our facility and we processed it. So first, we cut open the aluminum can, put it in the water for injection. And once it is settled down, the water for injection is thrown and it has been reconstituted in the physiological saline. Subsequently, we autoclave it because we have to put it in human patient, need to make it sterile, and dispense it. As you can see here, some of the photographs. So this is the target, glass microsphere. I have put it in a quartz tube, then inside this aluminum can. It has been sealed completely because we have to put it in the reactor core. It has been sent to Dhruva reactor. Once the irradiation is completed, we have brought it back. You can see these are the lead shielded container because it is a heavily radioactive. Then it has been processed by my colleagues. You can see that in the background the lead shielded plants are there, which is equipped with the remote handling tongs. Inside that we processed it, then dispense it. Finally, it is packed and sent to Board of Radiation and Isotope Technology. It is a commercial wing of Department of Atomic Energy who usually deals with the customers, and subsequently it is sent to different hospitals either by air or through road transport, depending upon where the hospital is situated. Now we have done a very elaborate study about the yield, specific activity and radionuclidic purity of our product. Some of the results I have shown. So you can see here the radionuclidic purity is always more than 99.9%. That is the primary requirement, because we cannot have the other radionuclide present in the thermosphere because that will give unwanted dose. And you can see here we have very thoroughly determined what is the radionuclidic impurity burden, and that is really minimum. It does not matter at all. And you can see here the specific activity, that means what is the activity per microsphere. It needs to be minimum 3500. From where we have got the specification? From the TheraSpheres, because we consider that is the standard. And in our case, we produced is roughly 6000 megabecquerel per microsphere. But you need some time to supply it to the hospitals, which are not always in Mumbai, which are very far away from a big country. But when we have injected in patient, we maintain that it should always be more than at least 3000 megabecquerel per 3000 becquerel per microsphere. Its radionuclidic purity, as I mentioned, is always more than 99.9%. Radiochemical purity is more than 98%. That is the requirement. In our case, we always got close to 100%. You can say. Of course, the product is sterile and apinogenic because we need to inject it into the patient. So here's the comparison between the TheraSphere and the BHABhasphere, and you can see more or less it is closely matching with TheraSphere. Only thing that TheraSphere is available between even 10, 15 or 20 gigabecquerel doses, but at this moment we supply between 3 to 8 gigabecquerel doses. And here I want to mention here every dose is patient specific. There is no standard dose. It depends on the tumor burden of the patient, disease condition of the patient. So we collect those information from the treating physicians, treating doctors, and whatever they tell that this patient will need 100 millicuri or 150 millicuri, accordingly we can back calculate and produce it. So it is a really personalized treatment for the patients. And you can see the specific activity I have already mentioned, and also the product purity that also mentioned, but for TheraSphere it is not quoted, so we don't know. Now, after doing it, we have done a thorough biological study because we need to approach the regulator before we put it in the patient. So it's really a very tough job, but again, thanks to the very multidisciplinary people available in BRC, the expertise available in BRC. We have a veterinary surgeon available with us. So we have done really the surgery in the rat, and it's really tiny. To put in the rat hepatic artery is really a very difficult job, and there should not be much blood loss, otherwise the animal will not survive. So we've done a thorough surgery in the animal, put these particles in the liver of the rat, and then again we have done the stitching, and this animal survived at least 7 days. So you can see here the results after the say the requisite time period is over, we sacrifice the animals, we dissected it and see where is the activity line. And you can see the majority of the activity is in the liver. So that means that what particles you have made, it stays in the liver and does not distribute in the body, which is one of the prime requirement. So subsequently we approach the regulator for getting the permission to put it in the patient. We got the permission, we started doing the patient, but one of the major problem we faced is that when we try to put it in the patient, you have to put it to the hepatic artery of the patient because it is very minimally invasive process. But the problem is the back pressure is so high, we are not able to put the particles. So we need a delivery system to be developed. And again, we collaborated with the Tapas Memorial Hospital and our colleagues from BRIT. So with a lot of effort, they have developed this delivery system, which actually helps us to deliver this dose properly. So you can see here some photographs of the clinical administration of the agent. So this is the delivery system what has been developed, and here it is the patient in the cath lab of the hospital, and you can see some of the patient's images. So the lobe which is actually affected, the Bhabhasphere is going there, and you can see it is growing actually. This is the image because atrium, though is a pure beta emitter, it has a very small component of gamma with which you can do the imaging. So you can see the imaging here, and you see that the liver lobe which is affected, the microsphere is sitting there. And so we have started in February 2021, but unfortunately then COVID came, so we could not progress further. And then the problem of delivery came, so ultimately we started to solve all these issues in the middle of 2024. Until now, in last 1 year, we have supplied around 36 patient doses in different hospitals. You can see here the list of hospitals where we have supplied these doses and patients have been treated. And we have also published our work, but again, this publication is not our main objective. Our main objective was to develop a biosimilar with which we can treat the Indian patient. And so in conclusion, I can tell that this radioembolization is one of the major method of treatment for the patients who have the multiple nodules and who cannot be treated by the surgeon. So, but they have a good life expectancy, and at this moment they are treated with these two microspheres, atrial level microspheres, sarspheres and theraspheres. But unfortunately, the cost is so high; it is almost unaffordable to majority of the Indian patients. So we have tried to develop a biosimilar, and that is informally called as Bhabhasphere, and the agent has been clinically translated after obtaining the regulatory approval of the competent authorities. And so far we have done only the limited studies, as I mentioned, only 36 patients, and the preliminary results are quite positive because what we have seen that tumor size, nodule size is decreasing, liver function is increasing, liver function is becoming better. But of course we need to do a very clinical studies in a large cohort of patients to know really efficacy and long-term efficacy of this agent. Just to conclude, I can say that Bhabhasphere, which is of course a significant step in nuclear medicine towards the goal of Atmanirbhar Bharat, as stated by our Honorable Prime Minister of India. So now we have transferred this product to our sister concern, Board of Radiation and Isotope Technology, and it is available from them. I can quote that the price is somewhere close to 1 lakh rupees. So with that, I will conclude my presentation, but I want to acknowledge few people because it is really a multidisciplinary work. I want to acknowledge all my colleagues from Radiopharmaceuticals Division, my colleagues from the Glass and Advanced Material Division who have developed this glass microsphere, and Reactor Operations Division where we do the irradiation. Also my colleagues from Board of Radiation and Isotope Technology for developing this delivery system, as well as for taking care of sending it to different hospitals of India. My colleagues from the Tata Memorial Hospitals who have given us a lot of guidance, what is required and how we should go, etc. All the doctors who are involved in this. DAE Radiopharmaceutical Committee, who is a regulatory authority who gives the permission for doing the clinical studies with radiopharmaceuticals in India, and all our clinical collaborators. So, thank you very much for your time.
Thank you for the lecture.
Thank you, sir.
Any query?
Yes, please.
Thank you, that's an wonderful role. I
Thank you.
have a question about retention. So after those nodes are healed, do you need to remove them, the residual radio particles, or they're safe to remain there?
They will have to remain there because liver is a very big organ. So even if they remains there, nobody removes it. All over the standard practice is left there because these are not biodegradable but biocompatible material.
Maybe I would have a question also in this direction. How is it with the half-life of the ethiopic? So when is the effect gone?
When is the effect gone? Oh.
Yeah.
So Ethium has a half-life of 64 hours, somewhere between 2 to 3 days. So you can say maybe it will give the dose at least 3 to 4 half-lives. So somewhere maybe 8 to 10 days it will give the dose. But it does not have a gamma. So it will give the dose to that organ because you know the beta has a very small range and gamma has a longer range. So from outside nobody will get any dose, but the tumor will get the dose, and it will be around 10 days when the patient will get the dose.
So, but that means also for the therapy you would require potentially frequent doses, or how would you expect that?
Yeah, it again depends on what is the condition of the patient. So far we have given only 1 doses and we are monitoring the patients. So it may be few patients may require even 2 to 3 doses also.
Thank you very much.
Thank you.
It was very interesting.
Thank you. Thank you.
I have one question. So, the mechanism behind the microsphere targeted only tumor cells, not any other cells.
See, I told you one thing about the blood supply of the liver.
Yes.
So when there is a cancer, when there is cancer formation in the liver, the blood is supplied by the hepatic artery. Otherwise, normal 75 to 80% blood comes from the portal vein. So what doctors do is that find out which hepatic artery is feeding those cancer cells, and you put your microsphere on that particular hepatic artery so that it automatically goes to the. So just like other radiopharmaceutical, there is no targeting mechanism here. Here you are putting it in the right place. That much I can tell.
Hepatic artery only target
Yes.
supply the
Majority, 25%, only the total blood supply, 25% comes from the hepatic artery. All other, but whenever there is cancer, it's almost totally fed by the hepatic artery because they need oxygenated blood.
So last question, I think maybe
Yeah, thank you for the excellent talk. Actually, what is the way you have done the clinical experiment in this
See.
hospital? Tata ma'am, is it academic trial or DCJ approved trial?
But for radiopharmaceutical, radiolabel product does not come under the purview of DCGI. So it has been given completely to Department of Atomic Energy. Yes, and we have our own radiopharmaceutical committee. The Department of Atomic Energy has own radiopharmaceutical committee, and once it is permitted by DARPC, we can go and put it in the
For
patient.
clinical.
Not only for clinical, we can even supply the products. Because all radiopharmaceutical what is marketed by us or BRIT is approved by DARPC. So it is,
You are in privileged position.
yes, you can say that thing, but it's not very easy to get permission from DARPC also. They are regulators.
Thank you, sir, for the